Welcome to Adapt NCLEX. One of the high yield topic on the NCLEX in nursing school is fluid, electrolyte, and IV therapy. This is part 3 of our pharmacology practice test, number 18. Practice question answers using critical thinking. This one is very challenging. It's challenging more than the 1 and 2. You want to stick around. We're going to talk about key electrolyte and medication and calculation, those calculations to help you master your NCLEX regarding fluid and electrolyte. First question, don't run away from you. I know you got it. Look at it. It's an EKG interpretation with the question. When you see questions like that, all they're giving you a bunch of data. They're trying to scare you. These questions are usually not that difficult. Use a test taking strategy and say, look, I got you. If I read this EKG, the answer choice is easy. What is the question asking? A nurse on tele unit receive a client cardiac monitor. That's what it shows. Which electrolyte imbalance is most likely responsible for the observed EKG changes? Look at it. There's something obviously wrong with this EKG. Your buzzword is what? What EKG changes? You have to read the EKG. If you look at the EKG carefully, I want you to stop the video. Try to read it. Try to find the obvious abnormality associated with the EKG. What do you think? If you look at it carefully, you can see that, there is some P wave here. You can see the QRS look fine, but these are information, this peak is abnormal. These are all T wave. It comes right after what? The QRS complex. This is what we call peaked T wave. And therefore, what electrolyte will give you peak T wave? Sodium does not cause EKG changes on its own. If you have low calcium, usually you have what? QT prolongation. If you have low magnesium, what do you have? You have Torsade de Pontes. And therefore, by default, this is an elevated potassium causing peak T wave. This is how they can take the content, turn into a question, and make it look like it's difficult. But the right answer is number 4. So we have peak T waves, which is caused by hyperkalemia. Next question, fluid electrolytes. A nurse is caring for several clients. Which client IV fluid prescription should the nurse question? This requires you to know what is isotonic, hypertonic, and hypotonic. Which of these are conditions? First, you have to know the condition. What fluid electrolyte problem is associated with this condition? Then you can pick the right fluid, right? So try this question, put down your answer, and let me know. SIDH, what do you think is associated with this condition? GCS of 9, what do you think is associated with that? And diabetes insipidus and blood pressure of that. Somebody with SIADH, that's what? Hyponatremia. And this is due to dilution. GCS will have cerebral edema. And we want to use some fluid to take away the edema. Diabetes insipidus, you're going to have high level of urine output and your sodium is going to be high. Your blood pressure is low. What fluid do you need when your blood pressure is low? Isotonic fluid. Diabetes insipidus, the sodium is going to be high. And therefore, we need hypotonic solution. We're giving them hypotonic solution. When your GCS is 9, we need hypertonic fluid to pull fluid from your brain. 0.45 is not hypertonic fluid. We have to worry about it. SIDH, your sodium is low. You need hypertonic fluid. 3% is an hypertonic fluid. Therefore, which fluid should the nurse question? This one. Any patient with a brain injury should get 3% normal saline, not half a normal saline. So there's no hypotonic fluid in the brain injury. This was worsening cerebral edema. It's something you already know. And I put a question together to show you the content and explain what you need to know about fluid management and how to use it to apply to clinical situation. Number 2 is the right answer. And this is preparing to hang a unit of packed red blood cell. Each question, there is a concept I want you to take with you. If you're watching this video, every question, write the concept down. And that is the purpose of this video, to give you all the concepts so that you can use it, whatever question they ask you. I'm not saying this is what is going to show up on the NCLEX. If anybody tell you that they have questions for the NCLEX, they're lying to you. You just have to know the concept. Know the concept to answer the question. What is the concept for question 3? What kind of fluid do you use for blood transfusion? That's all. What kind of fluid do you use for blood transfusion? Which IV solution should the nurse use to prime the blood tubing? 0.9% normal saline, D5W, lactate ringer, 0.45%. I know you've heard it before. Somebody show you in the video that you need a certain fluid to help with blood transfusion or prime the tube of blood transfusion. And this is the question they will ask you. What do you think? Normal saline is not compatible. D5W, is it normal saline, is it compatible with blood transfusion? D5W, is it compatible? Lactate ringer, is it compatible? 0.45%, is it compatible? The right answer, the only solution that is used for blood transfusion is normal saline. So only normal saline is compatible with blood transfusion. Therefore, number 1 is the right answer. Next question. A nurse is caring for a client receiving IV fluid via what? Central line catheter, right? They have central venous catheter, IV fluid. The nurse notes a change in the length of the catheter at the insertion site. Let's break it down. This is not a difficult question. This is not a difficult question. This is the patient. This is the IV going down here into the heart. And when you look, you mark here, this is 40 centimeters. Next time you saw, it was probably, now it's like 80 centimeters or 10 or 20. Whatever, the size and the location has changed. What would you do? Reposition the client, clamp the tube, attempt to flush the catheter to restore patency, or notify the air care provider. Think about it. This is critical thinking. You know the length that the insertion site for the catheter, central venous catheter, remember, is going to your heart. And therefore, you came in and there's a change. Do you change the patient position? Do you clamp the catheter? Do you flush it? Or notify the air care provider? This is something you're supposed to know. You will see it in clinicals. You will see it whether you're in nursing school, you see it in clinicals, you see it being applied. The first thing you want to do, because there is a change in length, this is what we call dislodgement, more position. Something is wrong. It's either it has gone in too far or it's been polar. You don't know. The best thing is to secure the tube so that it does not move anymore. Change of position usually used when the catheter is clogged. Most of the time when catheter get clogged is because the tip of the catheter is against the wall of the vessel, and therefore changing position would dislodge it. But this means the catheter has lengthened, either it's been pulling or it's coming out already. Something is wrong. And therefore, I will secure the catheter from coming out, or I will secure from it from migrating. Either it has gone in too far and probably is being embolized. Therefore, secure it. Don't flush it. That will push it in more. And then what do you need to do? Notify the provider. This is a concept you have to know. When you see this question, secure the tube before it goes in, and then let the doctor know, and he can fix it. So a change in length, or it may indicate whether they has migrated or is dislodged, and we got to secure it and figure it out. So number 2 is the right answer. This one is the challenging one. If you're in nursing school, this one is for you. Preparing for the NCLEX, I know you already mastered it, but to reinforce it, I'm going to make it simple as much as possible so that when you see these questions again, You will never run away from it. This is a dose calculation regarding magnesium, the loading dose and maintenance dose in the simplest form. They usually will give you a bunch of information, but don't freak out. Just stick around. Let me show you something. You will love to watch this. A nurse is preparing to administer what? Magnesium sulfate for a client with severe preeclampsia. At what IV pump rate should the nurse set the infusion? What? ml per hour. That's what. And they want you to do what? Loading dose. And you ask yourself, what have they given me? This is the loading dose. Don't worry. It's a bunch of information. That's the question will be. The loading dose instruction is what? 4 grams is to be given over 20 minutes. That's the rate they've given you. The pharmacy provide you what? Pre-mix. That means that's the available. So for LD, I have available dose, which is AD of what? They told me 4 grams is in what? 100 ml. That's all. And then they say what? The loading dose, I should have what? 4 grams over what? 20 minutes. You're already done. What do you need to do next is ask yourself, what are they asking me? They said I should set the pump ml per hour. So I write ml per hour. That's my answer, right? So therefore, I need the volume to be on top. The volume is here. You have 4 grams in 100 ml. So I write what? 100 ml over 4 grams. Should be multiplied by what? The loading dose. The loading dose is what? 4 grams in what? 20 minutes. And I want the time to be under. So 4 grams over what? 20 minutes. But I need the minutes in an hour. So I have 60 minutes and I have 1 hour. That's all. As soon as you set it up like that, you're done. All you need to do is to cancel that. What do you have? 20 minutes will go into 60 minutes 3 times. 4 grams will cancel 4 grams. And now you have 3 times 100 is what? 300 ml over what? Hour. This is our loading dose. Why is the number that high? Because it's the norm. Why is the number very high? Because it's the loading dose. You want to give it as fast as much as possible, 300 ml over an hour. And that is the loading dose. You're done. Straightforward. No confusion here. Now, let's go back to the maintenance dose. It's the same thing. What have they given us for the maintenance dose? It's the same information. The maintenance dose, they say what? 2 grams per hour, IV. That's the maintenance dose they want you to do. The pharmacy provide what? Premix, the same thing, but this one is what? 40 grams of magnesium in 1,000. You do it the same thing. You ask yourself, MD dose, the maintenance dose, they have given me available dose is what? Is the 40 gram over what? 1,000 ml. And then our maintenance dose, they want us to do what? 2 grams per hour. So what answer choice we want? ml over hour. That's the rate they want us. And I want the volume to be high on top. Therefore, I say 1,000 ml over what? The 40 gram. That's the first thing. Then you multiply by the loading dose. Then you multiply by the maintenance dose. You have 2 grams per hour. What do you have? That's all. 1 gram cancel gram, 2 cancel 40 into 20, right? 20 go into 1,000, what? 50. And therefore you have what? 50 ml per hour. The maintenance dose is slower than the loading dose. This is the way you do calculation regarding what? Magnesium. This is the straightforward. I want you to watch this multiple times and master it. These loading dose, maintenance dose, it can be confusing, but they are straightforward. 30 minutes into transfusion, the client developed dyspnea, crackles, and hypertension. What is the next priority action? Arrange from the first to the last. This is a concept. I know you know it. Stop the video. Arrange this in terms of prioritization. This is a patient prioritization. I want you to think about it. If you're getting fluid, transfusion, whatever, all of a sudden, crackles in your lung, dyspnea, and hypertension, this is what we call circulatory overload. What do you do? What actions do you take? Arrange them in the way you would take action in terms of prioritization. Do you position the patient upright? Do you give them oxygen? Do you call the healthcare provider? Stop the infusion and prepare to give them diuretic. Which action should be the first thing? Think about it. Patient is getting fluid and having circulatory overload. What do you think? Dyspnea, crackles, hypertension. How would you approach it? How good is your prioritization? And therefore, what would you do? Do you call the doctor right away? Do you prepare to give them diuretic? Do you stop the infusion? Do you position the patient upright? Think about it. There is a poison going. Therefore, what would I do? Poison is going to be stopped, right? I'm going to stop the poison. Then I'm going to raise the client upright. I provide some oxygen, call the doctor, and he give me a prescription for diuretic. Straightforward. Prioritization 101. This is the way it's supposed to go. And I know you got it. Number 7, halfway. What is your score? Let me know. I would like to know. I would like to read your comment. Put it down in the comment. Let me know what you're thinking. Number 7, this question is for you. I know you got it. What is the problem? A client with the serum sodium of what? 118, hyponatremia, and confusion, having symptoms. Bring your content. How do you treat hyponatremic patient with confusion? This is the severe hyponatremia. There's a strategy I tell people how to correct electrolyte. Consider your blood as plasma, and therefore its concentration is 0.9, which is the same as 1. If your sodium is low, right, that means less than 1%, what would I give you? If your sodium is high, that means it's greater than 1%, what would I give you? This is the way I do fluid electrolyte. Straightforward. I use this concept and they give me a question and ask, how would you correct it? Then I go back to this scenario. My 1% is isotonic fluid. Therefore, if I'm lower than isotonic, well, I should give you something higher than isotonic. If I'm higher than isotonic, I should give you something with what? Hypotonic, lower than isotonic. This condition, we have lower than isotonic because the sodium is 118 and confused. Therefore, I should give you a fluid that is what? Greater than isotonic fluid. Lactate trigger is isotonic, negative. D5W is what? Isotonic in the bag and what? Hypotonic in infusion. You never give this, it would dilute the sodium more. This is hypotonic. I should give you something higher. Therefore, hypertonic solution is the best answer choice. Therefore, this patient get 3%. And this is the way you should be able to understand it. Severe symptomatic hyponatremia need hypertonic saline. So 3 is the right answer. And next is caring for a client with central venous catheter. Note redness, warmth, purulent drainage at the insertion site. The client also has fever and chills. What do you think? This is infection. That's all. All these bars red is infection. What is the next first action? If you have a patient who has central line and has infection, what will you do? Do you get a caution? Do you apply sterile dressing on it? Do you let the doctor know or give them the antibiotic? Put down your answer. I want to know how you answer this question. But what do you think? Infection of IV line, what would I do? Content-based strategy, right? Prioritization 101. Infection, I have to be sharp. What does that mean? If I have infection, This is a bad problem. Central venous infection, bacteremia. Do I obtain culture? And then do I give them antibiotic or let the doctor know, apply steroid dressing? Steroid dressing is not going to change infection in the blood. Administer prescribed antibiotic. I have to get a culture first before I can give you antibiotic. You can't just obtain culture without letting the doctor know. He has to give you the order. He has to tell you, he has to know that this is a bad infection. I said in the previous video, if there's a bad problem happening and you have to do something, sometimes you have to call the doctor. This is the situation. He has to know that there's redness, there's worm, there's drainage from the tube line, and then we need to do something. Patient has fever and chills. I'm giving you all the signs and symptoms. You don't want to be the only person who know about this. Let the doctor know. First action is to notify the healthcare provider immediately. He will provide you with appropriate intervention. And then she's caring for a client with a central venous catheter. The same thing. This is the content. Look at it. Line is sluggish to flow. There is a resistance with flushing and inability to aspirate blood. I'm using the buzzword. Instead of giving you a lecture about this condition, I put it in the question form so that you can see how it behaves. Sluggish flow, resistant when flushing, and inability to aspirate blood. What is your diagnosis? Those are the buzzwords. Put it together and make a diagnosis. After you make a diagnosis, find the first action. What do you think if you're trying to flush a line that is resistance? You can't go. You can't aspirate anything, and blood flows through it is sluggish. This is what we call occlusion. It may be occluded. You don't know if the tape is occluded or whatever, or there's something, blood clot. I don't know. You let the patient take a deep breath and cough. You reposition the client. You notify the healthcare provider, or you flush the line. There is a procedure. There is a step protocol in this situation. When you see that central venous is clogged, what is the first thing? Prioritization. All the answers I can tell you, they are right, but you have to be sure. You have to know your content. How do you get rid of or figure out why this is not working? The first thing is what? Non-invasive. Always go with the non-invasive. Taking the deep breath and coughing, they're using something, right? Notifying the healthcare provider, you've not done your job. Flushing it, yeah. You don't know what is in the catheter yet. But the first thing is to figure out if the catheter is kinked off, the tip of it is against the wall. That is the number one. Most of the time when you have occlusion, is the tip is against the wall. So just by repositioning the client, you'll be able to get rid of it. Never forget this principle. Reposition is the first thing, is against the wall, followed by letting them take a deep breath or cough, or flush it gently. And if none of them work, then you call the doctor. And then she's reviewing IV fluid order. Which of the following fluid are isotonic? Isotonic, the key is what? What is the fluid inside your body, not when it's outside sitting on your table? 0.9%, what is it? 0.45% sodium chloride, lactate ringer, 5D5W, 3%. This is something, is the basics of fluid and electrolyte. And this is the fluid. Which one is isotonic? Normal saline is isotonic. 0.45% is what? Hypotonic inside your body. Lactate ringer is isotonic. D5W, when it's on the back, is what? Isotonic. But when the inside you is hypotonic. So overall, it's an hypotonic because we're considering when the fluid is inside you. 3% is hypertonic. Therefore, NCLEX step, always consider the fluid tonicity in your body, not just in the bag. Therefore, sodium chloride and a lactate ringer. 5 more questions. What do you think? A nurse is assessing a client with a serum calcium of 7. This is low. I will show you how to master calcium signs and symptoms because these are things that shows up on the NCLEX. These are things that shows up on the NCLEX. There's a strategy and I'll show you a simple way. When your calcium is high, don't memorize the symptoms. There's few that you have to know. But when calcium is high, your symptoms is going to go down. So most of the things they'll be complaining will be down, like depression, bone pain, those kind of things. When your calcium is low, think about things going up, excitable. Your heart become excitable. Your neurovascular system become excitable. Therefore, positive what? T sign, I call it. Positive T sign. These are what? Signs that are going up. Numbness and tingling in fingers. These are signs that are going up. Constipation. When you constipated, you're going down. Feeling of what? Skip heartbeat, palpitation. Things are going up. And syncope is a little bit different. Low calcium lead to what? QT prolongation. And that's how you passed out. Therefore, what are your right answer? I've given it to you, but I want you to understand, like when you have low calcium, think about things going up, like convulsion, seizure-like arrhythmia, right? Palpitation, right? Then what? Tightening, that means your muscle contraction and spasm. All these associated with what? Low calcium. Therefore, 1 is right, 2, 3, 4 is associated with hyperkalemia. Feeling your heart is skipping a beat, palpitation, that's arrhythmia, and the syncope, you passing out. So the mnemonic is CAT, convulsion, arrhythmia, tetany, and what? Spasm, hypokalemia symptoms. The nurse is receiving IV fluid prescription. Which of the following fluid matches the appropriate tonicity? Which one matches? It's the same thing. You see, I keep on reinforcing the information. You know what hypotonic fluid is? You know what hypertonic fluid is? You know what isotonic fluid is? And I give it to you, 0.9% normal saline. It's not hypotonic, it's isotonic. 0.45, what do you think? Is what? Hypotonic. D5W in water is isotonic in the bag, but hypotonic in infusion. 3% is what? Hypertonic. Therefore, number 3 is your right answer. The client is post-op day 2 following bioresection is MPO. Which IV fluid is most appropriate to maintain hydration electrolyte? Thus, require critical thinking. This fluid and electrolyte require critical thinking. This NCLEX practice question on pharmacology practice test require critical thinking. Why did I repeat myself? Because I want you to think and answer this question. I want everybody to try it, but look at it. Patient is post-op day 2. What do you think? And he has past surgery, MPO. I'm not eating and I need fluid. Which one will maintain hydration, electrolyte balance? This requires you to think which the fluid constitutes of all the answers I've given you. What do you think is in sodium chloride? What do you think is in lactate ringer? What do you think in D5W? And let's look at it. D5W is sugar and water. Lactate ringer, we have sodium, we have chloride, we have calcium, we have potassium, we have lactate. You see a bunch of stuff? Sodium chloride, we have sodium and chloride. Which one contains a lot of electrolyte? And if you're MPO and you are not eating anything, don't you need a bunch of electrolyte? Therefore, which one would you do? You can see that post-op patient, it's better to give them lactate ringer. And this is the best answer. Lactate ringer is isotonic, improve the your intravascular system. It contains a bunch of electrolyte, which you need when you have surgery. Therefore, number 3 is the right answer. If you pick number 1, it's okay. I just want you to understand there's some situation, the best answer choice, because of the scenario, bioresection, and I'm MPO, I'd rather give them lactate ringer. DKA, blood glucose of 540. We are applying the content clinically to situation, not to memorize. That is the purpose of this NCLEX practice question, is to use the information you know to answer it. If you've seen the question from somewhere before, don't memorize it. Look at the situation I've given you. That is how you answer question. DKA, the sugar is 540. Which IV fluid would you give them? That means you should not get sugar right now. That's all. At the same time, DKA patients are dehydrated. Therefore, they need isotonic fluid. Isotonic, LR is isotonic. Normal saline is isotonic. This one is going to do what? Give them more glucose, but it's not the first fluid you give them. They don't need 3%, too much sodium. This has D50, another sugar. The person's choice is normal saline. I know you know it's normal saline, but I'm trying to let you know is how you can break it down. Normal saline is the best solution for this. That's number one, because of the dehydration. And the last question is the continuation of what we saw, using the content associated with each condition. Every condition has its problem. A client with traumatic brain injury, I did not tell you what his DCS is, but I'm telling you somebody had brain injury. A brain injury patient is prescribed what? 0.45% normal saline at what? 100 ml per hour. What should you do if you are in this situation? As a nurse, what would you do? Do you give the prescription as ordered? Do you verify with the provider? Do you infuse at a slower rate? Or do you flush the line with D5W? What do you think is the buzzword? What do you think is the buzzword for this question? Write it down. It's this, 0.45%. 0.45% is the buzzword plus what? Brain injury. And look at these two buzzwords. Do they agree? Are they friends? Are they supposed to be together? If they're not, then you got to question. If they are, then you got to pick an answer related to being together. Brain injury should avoid hypotonic fluid. And therefore, if they don't agree, I know the right answer. Number 2 is your right answer. Thank you for watching. NCLEX practice question: electrolyte, fluid, IV therapy, and associated complication pharmacology practice test in our series. And know I've given you 3 videos. There's a 4th one that will follow, and that will be the comprehensive. The 4 together will be comprehensive for fluid, electrolyte, IV therapy. You have a library to master this. With a comment, let your friends know about it, subscribe to our channel, and good luck in everything you do.